So all of the previous parts to this discussion were basically aimed at trying to understand the basic concepts that will help us in simplifying this algorithm. This is the Adult Tachycardia Resuscitation Council UK algorithm. So let's start with this algorithm. Suppose we have got a patient who has got tachycardias. So now we need to manage them using, first of all, the ABCD approach and do the basic things, the most important of which would be the correcting any electrolyte abnormalities. The most common of which that we need to have a look is the potassium and magnesium, among other electrolytes. Then we need to see if they have got any adverse features or not. If they have got any adverse features and they are unstable, then this would mean that we don't need to find out what the exact rhythm is at that time. We basically need to focus on doing a synchronized DC shock, and if fails, we need to consider amiodarone IV. If they have not got any adverse features, then yes, we can try to work our diagnostic skills. Then we need to see if the QRS complex is, number one, narrow or broad, and number two, regular or irregular. So let's focus on the narrow complex tachycardias first. So if the QRS complex is narrow and it is irregular, so the RR interval is spaced at irregular uh, intervals, so the distance between the R and R intervals is not equal. You can simply measure the you can just simply have a look on the ECG to see, or more accurately, you can try to map the RR intervals on a piece of paper and then try to see if it matches with the other RR intervals or not. Anyhow, so the most common irregular narrow complex tachycardia is AF. So the emergency management points regarding AF is that we need to consider two things: management of the arrhythmia itself, which can be in the form of rhythm control or rate control. Now the most of this patient, this is a separate discussion which patient should be going for rhythm control or rate control, but most of them would be suitable for rate control, and in that sense we need to consider beta blockers, which are the first line. Unless they are contraindicated, then we can use a calcium channel blocker. If they have got a heart failure or say low blood pressure, then we can actually use digoxin. The other thing that we need to consider is the anticoagulation. AF is a huge topic, and then it needs a separate discussion regarding its management, and we will hopefully do it in another video, inshallah. Now if the QRS complex is narrow and the rhythm is regular, so all the RR intervals are regularly spaced, then this basically means we have got some possibilities that either the rhythm is a sinus tachycardia, or it is atrial flutter, or AVRT, AVNRT, classically called the SVTs, as we discussed in the previous videos. Now, sinus tachycardia would be obvious because each QRS complex would be preceded by a P wave. So each P wave would be followed by a QRS complex which is narrow, and then it would be a T wave. So there would be a P wave and there would be a T wave, so we can easily identify a sinus tachycardia. The actual difficulty is to identify if the rhythm is a atrial flutter or if it's AVRT or AVNRT, because they appear similar. AVRT and AVNRT are grouped together because the initial management is the same for both of them. Now, both of these atrial flutter and AVRT, AVNRT, categories, they appear as a narrow complex tachycardia, and if you have got the atrial flutter with 2 to 1 block, which basically means for every two impulses only one is being allowed to pass, so a heart rate of around 150. So this type of atrial flutter and the AVRT, AVNRT, they appear similar on an ECG with basically no obvious P waves and just regular narrow complex tachycardias. So this is where the difficulty lies, that we need to differentiate between these two, because the treatment for A is different when compared to treatment to B. So the easy way to differentiate clinically between them is to do the vagal maneuvers, because the concept behind this is, as we discussed previously, if someone has got atrial flutter, then this is the macro reentry pathway that's going on in a circle in the atria. Now, if we block the AV node by either the vagal maneuvers, which increase the vagal tone on the AV node, or by giving them a short-acting AV nodal blocking agent called which is adenosine, then this will inhibit the impulses going down, and we can see if the atrial activity on an ECG, which is usually masked by the ventricular complexes. So when we block the AV node, we can see the atrial activity, which would appear in the form of flutter waves. So when we are doing the vagal maneuvers and the or giving the adenosine, we need to make sure that we have connected the patient to a cardiac monitor, because these flutter waves is what we are trying to see, which are trying to unmask actually. How, on the other side, if the rhythm is AVRT or AVNRT, then if we do vagal maneuvers or give AV nodal blocking agents, then this will block the AV node, which basically would interrupt the re-entry circuit for AVRT or AVNRT. And we know if we block a component of the re-entry circuit, then it would basically terminate the arrhythmias, and this would translate into a sinus rhythm. Again, the patient needs to be on a continuous monitor for that. If the sinus rhythm is achieved, then this is probably the re-entry arrhythmias, AVRT or AVNRT, and then this needs proper management by the cardiologist. If the sinus rhythm is not achieved and we see flutter waves, or we don't see flutter waves, then this is most likely atrial flutter, and this needs expert help again in regards to if we need to do DC, basically if we need to do cardioversion in chemical or mechanical cardioversion. If we can control the rate in the acute setting as with AF. So atrial flutter is generally managed with the same guidelines as per atrial fibrillation. So again, we need to worry about the rate as well as the anticoagulation. Now, if the QRS complex is broad, then again we need to see if it's regular or not. If it's regular, then broad and regular, the most common cause is VT. So it should, if you're uncertain, then treat it as VT, because this is the more common as well as more dangerous arrhythmia. So it will be broad and regular. Of course, the other causes, as we discussed in the previous part, is any of the supraventricular rhythm, which may be sinus tachycardia or atrial flutter or AVRT, AVNRT coming down to the ventricles with a bundle branch block or through an accessory pathway. So these should be treated as for regular complexes. Regular negro complexes tachycardia, because they're just appearing broad because of not being originating from the ventricle as in VT, but being broad because of accessory pathway or the bundle branch block. Now, if the QRS complex is broad, then again we need to see if it's regular or not, and if it's regular, the most common cause is VT. So if you are uncertain, or if it's regular and broad and without any previous history of bundle branch blocks or accessory pathways, then treat as for VT, because this is the most common and most dangerous, and most advised treatment is amiodarone in that circumstance. If the other differential diagnosis, of course, as we discussed extensively in the previous parts, was This could be a rhythm originating from the supraventricular area, either a sinus tachycardia or an AVRT, AVNRT, or even an atrial flutter, and conducting down from either a patient, other a conducting system with a bundle branch block, or uh, with an accessory pathway. Now, if it's a bundle branch block, then it should be treated as for narrow complex tachycardia. But if they have got a history of Wolff-Parkinson-White syndrome, then it gets a bit more complicated. Then we need expert advice regarding that. Now, if it's broad and irregular, then they say seek expert help because this is the danger zone. The danger is this patient has got a pre-excited AF. Now, as we discussed previously, if the patient has got pre-excited AF, that means they have got an accessory pathway in the form of the bundle of Kent. That is, they have got the Wolff-Parkinson-White syndrome. Then giving them any AV nodal blocking agents would be horrible. So that's why we need to make sure and we need to differentiate the rhythm that it's broad because of the bundle branch block or if it's because of the accessory pathway. Of course, the most common irregular rhythm again is AF. So this irregular and broad means AF with bundle branch block or with accessory pathway. And this again, I'm stressing this: the patients with AF and bundle accessory pathway should not be given any AV nodal blocking agents like adenosine, diltiazem, verapamil, because this can cause them to go into VT as explained previously. So this is why it is important to see if if you have got a baseline ECG from the patient when they were not having tachycardia. This is important to know what their baseline morphology is like, if they have got a bundle branch block pattern or if they have got an accessory pathway pattern, that is if they have got a WPW syndrome or not, because when they have developed tachycardia can be difficult to differentiate between these two, and this broad and irregular rhythm can be very confusing. But this is important, of course, for obvious reasons, that patients with Wolff-Parkinson-White and accessory pathway are treated differently with imiodarone or other management pathways as per the hospital's cardiology guidelines and cardiologists, not managed as for the AF with bundle branch block, which is for narrow complex tachycardias. And to summarize the algorithm, so if when faced with a tachycardia, we need to see if they have got adverse features or not. First of all, of course, we do the A, B, C, D, E and see the adverse features not. If they have got, then we basically move on to the DC shock route. If they have not got these adverse features, then we see QRS complex. Is it narrow or broad? Now the narrow ones, is it irregular or regular? Irregular, of course, means AF. Or if it's regular. Now if it's regular, the causes are sinus or atrial flutter or AVRT, AVNRT. If the flutter waves are obvious, then of course it's easy to differentiate, but if the flutter waves are not obvious, then these two need to be differentiated. Now we need to see a differentiate between atrial flutter with 2 to 1 and AVRT/AVNRT. Both of them appears very similar on ECG with narrow complex regular tachycardia. So differentiation points are either vagal maneuvers, and if they fail, adenosine. 6 milligrams, then 12 milligrams. If it fails, and then 12 milligrams, 3 attempts. Vagal maneuvers can either be carotid massage or they can be Valsalva maneuvers, one of which is blowing into a 10 ml or 20 ml syringe. If this is successful or not. Successful, not successful. Successful basically means this was a AVRT or AVNRT. If it's not successful and you see flutter waves, this is atrial flutter, and you treat it as AF, similar to AF, same management as AF basically. Now, if it's prod, again, regular or irregular. If it's regular, then most common cause is VT. You treat as VT. If it's unobvious, you treat as VT. If it's other causes include causes of narrow complex tachycardias with bundle branch block or accessory pathway. Now, if it's irregular, this is basically AF. Now we need to see if the AF is present with bundle branch block or if it's present with accessory pathway, which is Wolff-Parkinson-White. And here we need to remember that again we don't give them AV nodal blocking agents because this can precipitate VT or VF for them, as we discussed in the previous lecture. So thank you very much for listening to this video. So this brings us to the end of this lecture, and hopefully we were able to simplify the tachyarrhythmias a bit. Since this is our first video, so we were not if you felt the layout and the things were not very smooth, then please, we apologize for that. But if you have got any suggestions or if you want to make any other recommendations, please let us know in the comments or on the Facebook group. Thank you very much. Have a good day, and if there are any questions, they are most welcome. Bye bye.